Hello everyone. In this video we will talk about a neurological disorder which results as a complication of the rapid correction of the hyponatremia. She is a 55 years old female patient who was admitted in one of the hospital as a case of the hyponatremia, and because the sodium was corrected very rapidly, so she went on to develop a very peculiar disorder which we call the CPM, or central pontine mylenolysis, which should have been avoided and which should always be avoided with the help of the very careful correction of the hyponatremia. So let's see what is this case. So what is the definition of the CPM, or central pontine mylenolysis? Now if you concentrate on the name of the problem, this is central in its location, and it involves pons most of the time, and there is a mylenolysis. Mylenolysis means there is a lysis or breakage of the myelin sheath. What is myelin sheath? Myelin sheath covers the axon, and whenever there is damage to the myelin sheath, we call it the mylenolysis. And in case of the CPM, this mylenolysis, it happens as a result of rapid correction of the hyponatremia. The definition of the central pontine mylenolysis is it's a neurological disorder which results from the too much rapid correction of the hyponatremia. Now the symptomatic hyponatremia should be managed with the help of the 3% sodium chloride solution. When we say that the hyponatremia is symptomatic, these symptoms can be fits, irritability, coma, altered consciousness. So the definition of the CPM and why the patient can develop is very important to be understood. In order to understand the 3% normal saline, it's better that first we talk a little bit about the normal saline, which is 0.9%. If you try to focus on it, it's a 0.9% sodium chloride intravenous solution, and it contains 154 millimole of sodium and chloride. So this is the normal saline, or 0.9% sodium chloride or normal saline. In order to correct the hyponatremia, we most of the time we use the hypertonic saline, which is 3%. Keep it in mind, the normal saline is, so the 3% normal saline, which is also known as the hypertonic saline, should be compared with the 0.9% normal saline. So this is the solution which is specially designed or formed to correct the hyponatremia. This is 3% saline, volume is 1000 ml, date of production is 26th of February, and it will expire within 2 days, within 24 hours. And it should be stored at the room temperature. It's a high alert medications, and if you again focus on some of the facts mentioned by the pharmacy, they say it's identify the patient correctly before you administer it. This is such a sensitive solution. Confirm the rate from the peripheral or the central line. Always use RAID control device to prevent the free flow. This is such a dangerous drug otherwise. And we need to verify the rate setting to avoid overdose. Monitor the IV site for the sign of phlebitis and extravasation, and return unused drug to the pharmacy as soon as possible. Why as soon as possible? Why these things haven't mentioned on the normal saline? Because 3% hypertonic saline is a very sensitive drug to be used. The rate of the correction of hyponatremia should be 0.5 milliequivalent per hour, or it should only be 10 to 12 milliequivalent per 24 hour. So in whole one day, only 10 to 12 milliequivalent of the sodium should be raised. So in order to achieve this target, 3%. So in order to achieve this target, 3% hypertonic saline is started at a rate of 35 ml per hour, and we need to check serum sodium after 2 hours and then adjust the rate according to the level of the serum sodium. Serum sodium should not be rapidly overcorrected, because in that case patient will develop the central pontine mylenolysis, or the breakage of the myelin sheath, especially in the area of the pons, but it can also involve the extra pontine areas. If I show you the labs of this patient who was shifted to us from another hospital, what happened in this case? Patient sodium was 115 on 24th. It was 116 on 25th. So it was a sort of a chronic hyponatremia. But when 3% was used, they made the sodium rise from 116 to 138, which is well above the target range of the correction of the hypernatremia. So overcorrection or too much rapid correction of the hyponatremia made the patient to develop the central pontine mylenolysis. What are the features of the central pontine mylenolysis once the patient develops it? Patient may have difficulty in speaking, which is dysarthria. Patient may also have difficulty in swallowing, which is dysphagia. Patient may develop the memory disorders or disturbance. There may be personality changes. Patient may develop weakness of both upper and lower limbs. And sometimes these patients, when pontine involvement is very prominent, they are in the locked in state where they are looking around but they cannot move at all. So sometimes these patients go into the coma and they may also die because of the central pontine mylenolysis, which is because of the rapid correction of the hyponatremia. About the prognosis of the CPM, 50% of these patients die and 50% will recover. Those who recover will have intellectual problems and they will need a lifelong rehabilitation and physiotherapeutic support. The best treatment of the CPM is to avoid the development of the CPM. So people should be educated about the proper management of the hyponatremia.